Start paper that Rena D'Souza and Francis Collins and Vivek Murthy had in the New England Journal back in March. It ends by saying this century began with the recognition that oral health is central to oral health. Now it's critical that we build on this knowledge and the scientific progress we made to ensure that oral health is fully integrated into this new era of discovery and to harness policy changes and technological advances to disrupt systemic inequities. Only then will we truly improve the health of people, families, and communities. And I firmly believe that. So I will talk about redesigning and improving healthcare by integrating oral and medical research and practice, something I am quite passionate about. Innovation has its enemies, and very often organized healthcare groups are the enemies, whether it be the American Medical Association or the American Dental Association. So the real question is, can we create dental medical champions for change? In fact, I think you introduced one at your own institute, someone I know, and that's Janice Lee. So what I'd like to do is review the history, more recent discussions about this topic, and the possibilities for change now. The next slide, please. Am I controlling it? No. So I think one of the things that we have to consider in doing this is changing the scope of dental practice. I think that there's a place for oral health in primary care. I think we need to think of change versus continuity. We need to think of innovation versus incumbency. And two of my favorite areas, disruptive innovation, which was the brainchild of Clay Christensen, who's no longer with us, and catalytic mechanisms, which are little things that can really stimulate some real changes. The next, please. In certain of those changes, I'm reminded that about 2.5 years ago, the American Dental Association had an announcement that said that all dentists should advocate for patients getting HPV vaccination. And my response to that is, why don't dentists give HPV vaccination? We give big mandibular blocks all the time. What's the big deal of a little vaccination in the arm? But let's return to a brief history of this topic in the United States. The Baltimore College of Dentistry was the first dental school in America. But what if it had become part of the University of Maryland Medical School? No one's quite sure if the dentist originators didn't want to join or the medical school didn't want them. But just think of what would be different if that dental school was part of the medical school. Next, we had my own institution, the Harvard Dental School, which caused all sorts of problems in 1867 by forming a dental school and giving a DMD degree. How silly. And now we have some dental schools changing from a DDS to a DMD degree. Other things that have resulted in big changes was the closure of 5 very excellent dental schools in the late 80s, early 90s. Wash U had a wonderful dental school. Georgetown did. And I could go on and on. The bright spot came when Arizona started a new dental school, and it was the first to really emphasize public health in its curriculum, and kudos to Jack Illenberg. But most of the dental schools that have come about since that time have been predominantly osteopathic associated schools, and there have been few university-based dental schools that have come into existence. The next slide, please. So there have been attempts at medical dental education through the years. And just a quick review, the Guy's report said that dentistry should always be aligned but separate from medicine. William Guy's was a biochemist at Columbia. Alfred Ower was the dean at Columbia. He was a dual degree dentist, and he was passionate about medical dental integration. And guess what happened? The First District Dental Society of New York City ran him out of town. In the 1930s and early 1940s, Dean Winterlitz at Yale Medical School was very progressive and developed an MD program for dentists. He felt specifically that it would improve their knowledge and ability to do research. And although the program was cut short by World War II, there were some real stars who came out of this. And I want to use that to emphasize the fact that experiments are important and pilot programs are important. So just 3 people who came out of that program: Lester Burkett, who started oral medicine at the University of Pennsylvania.
Yep.
Seymour Kreshover, who wound up being a director of the NIDR, and David Weisberger, who was a leader in oral cancer detection, Sjogren's syndrome, and was my teacher at Harvard. Then there was the Harvard experiment of 1940, doomed to failure, where everybody coming into the dental school got both an MD and a DMD. And then the very successful MGH oral and maxillofacial surgery program, which began in 1971 and which now numbers about 50 plus programs. The important thing about the last program is that program came about because of the desires of applicants. It wasn't necessarily the desires of academics or people in power. The next, please. There have been a number of reports of importance. The Guy's and Flexner report, which I've mentioned. Dental education at the crossroads from the previous Institute of Medicine in 1995 was a wonderful report. In fact, recommending certain changes and certain stability in education. It had on its colors lavender and green, the academic colors of medicine and dentistry. But in fact, there were studies that showed it was read by less than 15% of people in the health professions. And then there was the 21st Century Guy's report led by Alan Formicola and Dr. Bailett. That was supported by the ADIA and ADA and other groups. And that was a very substantial report, but really led to very little change. There were lots of suggestions, some really key players, including Laurie McCauley, Peter Poverini, myself, other people wrote very erudite papers. But you know, the people and the area you're trying to change have to want to change. And then there was the very successful Oral Health in America report that started out as a second Surgeon General's report, but was eventually issued through the NIDCR. On the right is a paper by Hendrickson and Peter Cohn, Oral Healthcare in the 21st Century, Implications for Dental and Medical Education. This came out in December 2001 in Academic Medicine. And in fact, it was the last paper on this topic that appeared in a medical education journal. That's telling. Next, please. Now, there are strategic priorities for the NIDCR, and I'll highlight this paper, which appeared in Frontiers, which is authored by Dr. Meridian, Janice Lee, Will Entz, and Martha Summerman, and it called for these priorities for the NIDCR: to integrate oral and general health, to develop more precise and individualized treatments, to translate and implement that new knowledge, to create a diverse research pipeline, and to partner and collaborate to make that part of one's being, so to speak. The other thing I must say, having seen this primate come out, Whenever I would see Martha Summerman in a meeting, she knew how I felt about the PBRNs. And so she'd always try and change the subject. So really, Irina, I'm really happy that you're doing Pri-Med. The next one, please. Next slide. Thank you. So the main issues for change now, which you've heard about before, and which I'll try and make the point that a dual degree can help achieve: access and disparities of care, particularly the underserved groups; to save and renew the endangered dentist physician scientists to advance science and medical treatment of surgical disease; to advance and integrate behavioral health, mainly because of its role in addiction; the aging of our population and its unbelievable increase in chronic diseases, what Richard Watts has called multi-morbidity of disease in Lancet papers, maybe even relieve the primary care shortage, and to teach oral health to medical students and residents, because I do not think that interprofessional education is doing it. The next, please. But change is hard. And just, I'm a storyteller, so I'll tell a few stories. Atul Gawande, in a paper in the New Yorker called Slow Ideas, talked about how quickly ether anesthesia, the anniversary of which is coming up in October, how quickly it was adopted by the medical community. And in those days, 1846, about the only operation that we did successfully was amputations. But that was really latched onto, versus Lister's idea of asepsis, which meant work for the doctors and was very slow in being adopted. And I always draw the comparison between taking care of HIV infections and implants. Implants were adopted like wildfire. Well, the dental profession was very slow to deal with HIV-infected patients. Linsky has talked about adaptive versus technical change. We're good at technical change, but adaptive change is really transformative. And I think that's what you're trying to do, and that's what I'm trying to talk about. It always involves a loss for someone. And that's hard for professionals who have been at their work for some time, taking great care of patients, to admit. So 2 quick stories from 1973. Secretariat was a great racehorse. He won the Kentucky Derby, he won the Preakness, and then he stopped training. He wouldn't run well, and the Belmont was coming up, and his trainer called a veterinarian. The veterinarian came to see the horse and found a dental abscess. That veterinarian wasn't restricted by any practice acts in doing what he needed to do to take care of that infection. He drained it, and Secretariat began to train and eat and won the Belmont by 23 furlongs. When I was a medical student, I was asked to see a patient at a particular Harvard hospital who had 105 fever, was relatively comatose, and they were sure had meningitis, but they couldn't find the source of the infection. Well, lo and behold, looking in the mouth disclosed an infected maxillary impacted wisdom teeth. Physicians don't necessarily look in the mouth, and that's what my call is: put the mouth back in the body. Talking about some of the things you work today in terms of databases, I remember when the Jupiter trial of C-reactive protein and statins came out, I met with Paul Ridka because I was very surprised that they had 17,803 patients, but not one dentist was involved in the study. There was no examination for periodontal disease. And you know what? They just didn't think of it. And last but not least in this category is the group of dental students who met at our place for a student dental association meeting, and they asked to see me, and they came to see me, and this was their problem. They said they learned about basic science, and they were taught by the medical school faculty at their institution, but every lecture started with, We don't see why you should know this. Sad. Well, we should know this. The next slide, please. In this paper, it's time for a new Guy's report, which I wrote in 2009 or something like that. The important point is that experiments can work. This talks about a lot of different kinds of programs. One of the most successful, our previous speaker, is a product of the Doctor of Medical Science program, which was initiated by Paul Goldhaber. There were 153 people who went into that program. 93 stayed in full-time academics and research. Amazing work. I mean, those are the kinds of things that really work. And it's interesting that other programs in that category was the oral science PhD program at MIT that eventually had an NIDR training grant run by Dr. Robert Harris, Mike Alfano, and several other very well-known people went through that program. So the kinds of things that you're considering doing as experiments and pilot programs are important. And to the right, integrating oral health and general care, the important thing is, as Lena has pointed out, that the Dental Institute came about because of the failure of people to be drafted for World War II. We needed 7 maxillary and 7 mandibular teeth to pull a pin on a hand grenade. And if you couldn't do that, you couldn't serve in the service. In any case, it's come a long way since then. But I think medical and dental education and medical and dental research need to stay together and be involved. Next slide, please. Next slide. Thank you. So here's the introduction to advancing dental education. This was the 21st century Guy's report, which looked at the profession in great depth. And indeed, the problem is that people don't want to make changes. We introduced interprofessional education. We talk about a lot of things, but indeed, most of dental education is about procedures. And on the right was attempts we made at Harvard to introduce an integrated primary care dental services clinic, which has worked out with nurse practitioners very well and has been a model for other people to copy. Next, please. Monty McNeil at UConn made a very good case for integrated oral and primary medical health care delivery. And a few years ago, I wrote with the dean of the medical school that it's time for the integration of dental and medical education. And we're still at the point of negotiating those changes because you know what got in the way of pandemic. The next, please. Here's Rena's paper, that Oral Health for All, Realizing the Promise of Science. And it really is well written. But on the right is a piece from the Science Times, Tuesday in the New York Times, behind health-robbing ailments, inflammation. And guess what is not mentioned at all? Periodontal disease. So we have a lot of education to do. We can't just talk to ourselves. Next. Next. There have been several recommendations for a review of institutions that have done medical dental integration, Kaiser Permanente, the Marshfield Clinic, and Health Partners in Minnesota. A greater emphasis should be placed on foundational and applied medical education within the dental curriculum. Dental schools and other dental education institutions should pursue an integrated multidisciplinary approach in the overall curriculum. Dental graduates should become more skilled in using health analytic tools and in the interpretation of summary information from the large sets of healthcare data available. They've talked about that. Education and training to function in teams with other healthcare providers, not traditional interprofessional education. And dental education must make a bold move to acquire electronic health record systems, which I think is important, but changing the culture of the profession is much more important. The next, please. So I used to only have these things here. How do we opt for change? We can change the practice acts in the face of politics, very difficult. We could add IPE practice and nurse practitioners. We could change dental education, not an easy task. But I like the idea of a dual degree and residency that would make someone the equivalent of anyone else in healthcare, so that you could really develop champions for putting the mouth back in the body. You don't need 1,000 of these people. You don't need 150 of these people, but maybe 50 to 100 could change the scene. And in fact, although the original plan was for dental school to medical school as part of this kind of training, followed by appropriate residency, we've had 2 opportunities now for medical school students to come to dental schools with advanced standing, which is an interesting way to do it. We're working with 2 very fine medical schools that don't have dental schools to try and accomplish with. And in fact, the whole idea of what you've done here in transforming the PBRN to PriMed is very exciting to me. I haven't had a whole host of time to look at this, but I think although it was meant to move PBRNs and research out of the private office, even under the influence of the dental service organizations, I think that the important thing is, could you do this in a way that it's not only in dental schools, but in medical schools or in hospitals, so that students worked with other members of the health profession? And I think since this has come out and rereading, and I think that's a real possibility. Someone just asked about GPRs. I served for 7 years with Alan Formicola on a committee to make GPRs more important. And in fact, we didn't get very far. Just like oral medicine in this country, there are 7 programs nationally. The next slide, please. So we want integrated care, we want integrated financing, and a true interprofessional practice. And we should think of the teams. Someone's mentioned that before. The cleft palate team is a perfect example where people get to practice this in a very interesting way, begun at the Lancaster Cleft Clinic in Pennsylvania. I think it's a great model. The next, please. Clay Christensen was a great friend. He was a professor at the Harvard Business School and the originator of disruptive innovations. And he used to say, when I want to get a present for someone, I would go to Best Buy. If I wanted to get something to fix something around my house, I'd go to Home Depot. But then I could go to one store, Walmart. And if I needed gasoline, I'd go to an Esso gas station. If I needed a snack, I'd go to a 7-Eleven. But then I could go to an integrated gas station snack place to accomplish this. And he was a great fan of the idea of integrated practice. Next, please. So there have been lots of major reports. We have enough reports to last us a lifetime. The IOM report, the first Surgeon General's report, ADIA's efforts in interprofessional alliance, the 21st Century Guys report, the Dentist Scientist Workforce issue, and the 2020 Surgeon General's report on oral health, which we all know about. The next, please. The next. Next. I put him to sleep. Don't let a crisis go to waste, and we've certainly had a crisis. The pandemic, many smarter people than I have written about what it's done to healthcare, economics, and public health. But what I remember is in the early 1990s, when I was still chief of oral and maxillofacial surgery at the Mass General Hospital, I heard for the first time the term covered lives, not patients. And at the same time, we stopped calling people doctors and began to call them providers. Well, covered lives and providers have dominated healthcare delivery since that time. Theodore Roseberry, on the 30th anniversary of the Guy's Report in 1955, believe it or not, made an interesting statement that up until that time, which was 1955, dentistry had had some big wins, i.e. fluorides, but they really had not developed any treatments, medical treatments of disease that could eradicate disease. That's what we still need to do. Medicine has been able to do it, and that's why science is much more a part of medicine than it is dentistry, unfortunately. Vannevar Bush, who was President Roosevelt's science advisor and really set the stage for the NIH, really believed in science. Vietnam War, for those of my age, remembers the Yellow Berets who went to the NIH and became outstanding scientists. And I think that's what you're trying to do again. And then I also remember change is possible. The National Institutes of Dental Research became the National Institutes of Dental and Craniofacial Research under Dr. Slavkin. So I think the alliance between medicine and dentistry is more important now than ever. It signals a commitment to science. I do not think the status quo is inevitable. And I think education and research can drive the profession. And that's an important role for the NIH and the NIDCR. Next slide. Next, please. So there have been lots of report on medical dental integration. Dentists as physicians of the mouth, which I wrote in 1993. Stakeholders who were interested in this. La Cascada Declaration, written by some world leaders, talking about integrated medical dental education. We've started the Harvard Initiative for Integration, SIPCO, Center for Integration of Primary Care. And in fact, under this auspices, the first dental residency in New Hampshire has been approved and will start very soon. Imagine that, no dental residencies in rural New Hampshire. So the question is, how do we create leaders? That falls back to the program that Dana Graves is running, and I'm happy to be part of. We need mentors, we need year-out programs, and we need to change the culture. The next, please. So we need to create catalytic mechanisms for change. Dual degree programs in primary care designed to foster teams of care might work. Model after the dual degree oral maxillofacial surgery programs. It was designed to permit surgical training at an appropriate level of responsibility, which is enabled by the MD. And that's what this educational program is about. Make oral health part of overall health in practice and research, and save the endangered dentist scientists. I really think it's possible. Next, please. Other important issues, it's being taken on by the world, but we have to deal with the United States. The physician scientist workforce report that Dr. Graves talked about is very important. We see business playing this game, Amazon buying One Medical, and last but not least, what the pandemic has done with the loss, vacant budgeted faculty positions in US dental schools. It's incredible. Who's going to teach Who's going to teach? The next, please. So here's dental education at the Crossroads, Institute of Medicine, 1995. If you have a chance, read it. William Guy's report, pretty good report, read it. Innovator's Dilemma, excellent first book of Clayton Christensen, read it. Blue Ocean Strategy, an interesting book that talks about different ways of thinking about it. And just consider this, Ringling Brothers and Barnum and Bailey Circus no longer exists, but Cirque du Soleil is thriving, so change is possible. But most of all, the most innovative thing ever is an Oreo package, which you can just open by ripping the flapper. Very important. The next, please.
It's stereogenic, though.
Stereogenic, sorry. I really believe in this. The key to reform of almost any kind in higher education lies not in the way that knowledge is produced, it lies in the way that the producers of knowledge are produced. And that's from the Marketplace of Ideas by Louis Menand, who teaches at Harvard. And if you haven't had a chance to read it, so I can get in more trouble, this is a recent August editorial in the Journal of the American Dental Association by myself and the future Lisa Simon about what needs to happen in dental education. Thank you very much, and I'm happy to answer any questions.
Thank you, Dr. Donoff. Are there any questions? Or comments?
It's Terry Dickinson. So love so many of the things you said, Dr. Donoff. I think there are some bright spots out there. I know personally of one at Carilion, healthcare system in Roanoke, Virginia. They've done this for a number of years. They had a champion, which you speak to, and that's what you need.
Yeah.
But they really integrated dental into the medical school there. And so you're right, there's not many of them out there, but there are some out there. But boy, it depends so much on that champion that's willing to put the time and energy and heart into getting that thing to work. So we just got to keep trying.
That's a great program.
Thank you. And then I would say also, Bruce, that if you remember the days when Margie, God bless her soul, Jeffco ran those studies where she compared, it was Delta Dental and another cohort of records that she looked at to show that if you actually treated gum disease or periodontal disease, whatever stage, that you had less of a chance, or you were able to alleviate cardiovascular and vice versa. So she showed that oral systemic early data set. Now, in a way, creating the holistic physician who's oral health and MD trained allows us to create the actual evidence that that integration is necessary, right? So I see another advantage to training individuals, a small cadre of thought leaders who would say, you know, I've got this whole patient, I'm looking at everything from head to toe. I'm not cutting the head and having it float in space, because vision and hearing is also lost in space. They're not covered in universal health coverage, as you know. So yeah, so I'm hoping that Dana, I encourage Dana's group to actually be looking at this as a model, a testing system, perhaps, that we can consider or launch into. So
I
thank
will
you very much. Jeff.
Thank you for asking me to speak.
Thank you, Dr. Donoff.
Jeff.
Yeah, so this is Jacques Noor from University of Michigan. Excellent presentation, Dr. Donoff. I was intrigued when you were talking about the review from Kaiser Permanente about going beyond traditional IPE programs. Can you expand a little bit more on that?
Well, I haven't visited out there for about 3 years, but they had clinics where they actually did this. They had physicians and nurse practitioners working together And of course now Kaiser has their own medical school in Pasadena. And since I knew the dean at Children's Hospital in Boston, I tried him to form a dental school, but he ran out of money. In any case, yeah, I think this can work. You don't have to be the dentist who is going to do every procedure, but you certainly need to be someone who, listening to the conversations about oral cancer detection today. You know what the leading cause for suits against dentists is nationally? Failure to detect an oral cancer because they don't look in the mouth.
Yep.
So what good does all the fancy science do?
Yes, and then we have Kaiser, who's been very, very proactive in creating the interface between Epic and Axiom. So they have 10 million records through Ocean. Jennifer's been talking to them, offering us data mining opportunities, because these are both medical and dental records from the same patient, and over time. So that would be another. We need people who are trained to be looking at those records from a data mining perspective as well. Yep, a lot to do.
Thank you.